This video in the Clinical Toxicology series is about caustics, corresponding to Goldfrank's chapter 103. The learning objectives for this session are that you'll be able to define what a caustic substance is, describe and differentiate between the tissue necrosis patterns seen with acids and with alkalis, and outline the evaluation and treatment plans for caustic exposures. The definition of a caustic is any substance or means which, applied to animal or other organic tissue, burns, corrodes, or destroys it by chemical action. I hope it's not too surprising that there are many caustic agents that can be found around the home as well as in industry. And the cute photo on the bottom left is to remind us to keep the dangerous chemicals away from kids who aren't aware enough yet to protect themselves. Just think about all the products you have right now under your sink. It's just frightening sometimes. Most caustic agents are either strong acids with a very low pH, like hydrochloric acid, as may be found in swimming pool supplies or in toilet cleaners, or they're strong alkalis with a very high pH, like sodium hydroxide, as found in caustic lye and drain clog removers. The mechanism by which acids kill cells is coagulative necrosis. The acids coagulate the proteins in cells, basically pickling and preserving them, since the normal enzymes that would break down the cells shortly after death are also denatured at the same time. Thus, acid-burned tissue preserves the original architecture, at least initially, and the burned tissue forms an eschar, which limits the depth of injury. The surface is burned, but the burned tissue somewhat protects what's underneath. This is in contrast to alkalis that produce liquefactive necrosis. Alkali transforms the affected necrotic tissue into a liquid that does not maintain its original architecture and sloughs off, allowing the deeper tissues now to be exposed to the caustic and allowing for deeper and progressive injury. So, although caustic burns are never nice, if everything else were somehow equal, like the amount of exposure, concentration, duration of exposure, etc., you'd probably want an acid burn over an alkali burn. I like to think of an acid burn's coagulative necrosis kind of like turning the skin into leather, but the liquefactive necrosis from alkali saponifies lipids. This is to say, it turns the fats in your tissue, such as in the lipid bilayer cell membranes, into soap. The chemical equation on the left shows how fat, triacylglycerol, reacts with a strong alkali like sodium hydroxide to release soap, sodium salts of fatty acids. In case you didn't know it, this is how soap is made. And the figure on the right shows how soap works, by forming micelles, where fat-soluble materials can become suspended in water because they get surrounded by soap molecules. Soap is amphipathic, meaning that it has a hydrophilic water-soluble side and another side that is hydrophobic. Alkali burns get slick and soapy, and the underlying tissue is now exposed. Where on the body a person gets their caustic exposure will guide the medical evaluation and therapy. For skin and eye exposures, that is, external exposures, the indicated response is quite straightforward. The other main exposure mechanism is caustic ingestion, and internal exposure, and how one evaluates and treats caustic ingestions forms the bulk of the chapter material. We'll be looking at decontamination methods, endoscopy, corticosteroids, and potential surgery. External exposure is treated by removing contaminated clothing, showering or other copious water irrigation, and then local wound care. Anything other than a trivial chemical burn should probably be referred to a burn specialty center. If the exposure is to the eyes, we'd really like to irrigate those too. Any significant irritation to the eyes, though, can produce blepharospasm, where the muscles around the eyes go into spasm, making it very difficult for the patient to open their eyes, when that's exactly what we'd need, is for the patient to open their eyes so we can flush a lot of water across the surface. There are a few setups to make ocular irrigation easier. You can tape an IV tube near someone's eye and drip fluid through it, or you can put the two prongs of a nasal cannula, usually used for oxygen, on either side of the nose to irrigate both eyes at once. And there's also the Morgan lens, a product specifically designed for ocular irrigation. We're going to watch about 1 minute and 40 seconds worth of video clips now, demonstrating the nasal cannula approach and the Morgan lens. Caustic ingestion can obviously result in severe injury to the gastrointestinal tract, starting at the top with burns to the lips and tongue. And here is an endoscopic view of the esophagus. All the tissue should be a healthy pink, but a lot of it here is grayish from burns. And here's the stomach of a person who died from a full thickness burn after an intentional ingestion of a brick cleaner containing phosphoric and hydrochloric acids. GI decontamination for caustic ingestions is generally avoided because most measures are either ineffective, harmful, or they obscure endoscopy, which is necessary for determining the degree of injury and what treatment is indicated. Most caustics bind poorly to activated charcoal, but even if they did bind better, we'd hesitate to give it to avoid obscuring endoscopy. You might think to neutralize a strong acid or base to reduce the amount of injury, and while you might mitigate the initial chemical burn, such neutralization is exothermic and increases pressures, which can further damage the tissue or even cause perforation. Thus, neutralization is definitely contraindicated. Investigations into whether dilution with water or milk will help have been done. And while it's possible to see the same kinds of adverse effects as occur from neutralization, they should be a lot milder. But the data is not convincing that these help, so dilution also is not generally performed. The indicated response is mostly, don't just do something, stand there. However, using a small nasogastric tube gently inserted to empty the stomach may be considered early on after large acid ingestions, where we think there's probably a considerable amount of acid still in the stomach due to pylorospasm. This is not done with alkali ingestions or when the nature of the caustic is not known. Liquefactive necrosis from alkali can acutely weaken the GI tract mucosa, and inserting an NG tube could rupture the esophagus or stomach, and that risk is much lower very shortly after an acid exposure. As already mentioned, we want the patient to have their caustic ingestion evaluated by upper GI endoscopy right away. Ideally, this would occur within 12 hours or even up to 24 hours later. Doing endoscopy even later than that, when the tissue may be even more friable, is thought to greatly increase the chance of perforation. There's a whole grading system for the degree of injury. You're hoping to see grade 0, nothing seen, or grade 1, mild, and these patients tend to do well. Patients with grade 3 don't do well, and those with grade 4 often die. With grade 2 injuries, the pattern of burns helps risk stratify who's at more or less risk of scarring that causes esophageal strictures. If a patient has longitudinal burns, grade 2A, that's more benign. But if there are circumferential burns, grade 2B, that's more likely to result in strictures. Corticosteroids are given to patients if grade 2B burns are seen to reduce the risk of strictures. The radiograph here is a barium esophagram taken 4 months after a caustic ingestion, and we can see the stricture here quite well, and also how the esophagus is also scarred down and very narrow below that point. You kind of need an esophagus to eat, and if the strictures cannot be managed by any other intervention, the patient will either need a gastrostomy tube for feeding, or they can get a colonic interposition surgery, where the scarred portion of the esophagus is removed and is replaced by a section of their own large intestine. I was moonlighting in an emergency department during my toxicology fellowship, and a very abnormal chest x-ray I saw in a patient reminded me that I had helped care for him about a year earlier after a caustic ingestion, and his abnormal chest x-ray was because he'd ultimately needed a colonic interposition. Here are a couple of mnemonic device comic illustrations that you might find helpful. If you like them, stop the video here and take a closer look. But I'm moving on. But only to say that we've come to the end of this video discussion about caustics and caustic ingestions. I'll be seeing you around.